Good evening. Welcome to the Gilead Symposium. I hope you had a nice day for the Paris meeting, and I wish you also a nice day for tomorrow and to enjoy also Paris. So this symposium is entitled Committed to Patient Care, Striving to Optimize Outcome in Liver Disease. You know that Gilead is committed to liver disease with treatment in Hep C, in Hep B, and many programs in NASH, so for all liver disease. These are my disclosures. So we will have a fantastic program. I am very honored and pleased to co-share with Professor Michael Malms from Hanover, Germany, very famous in hepatology and internal medicine. He will start with Hep C, and of course he has been involved in all the investigation and the trials and the study for Hep C. And we will discuss each time with a patient case, how to simplify the treatment of patients. Then we will have Hep B, and we are very lucky to have George Papatheodoridis from Athens, Greece, with his huge knowledge in Hep B management, and he will explain us how to manage the patients. And then a NASH with Arun Sanyal from US. He has been very important in moving in knowledge of NASH as investigator, scientist, and clinicians. At the end, we will have global discussions. So please do not hesitate to ask your questions. You can either write or discuss on the microphone. At the end, we will have a global discussion. We value your opinion also at the end of the symposium. If you have any things, how to improve, please feel free to give your comments. So we will immediately start with Professor Michael Malms. Michael, patient with liver disease, a changing landscape, and then the Hep C. The floor is for you, Michael.
Yeah, thanks very much for the invitation. And I would like to set the stage when discussing the changing landscape. This started as a meeting. Now we have the 12th meeting in Paris, and it started more or less as a viral hepatitis meeting. But the landscape is changing. These are my disclosures, and this is a very interesting editorial written by Tom Carlson, General Secretary, and Vice Secretary Frank Tucker. You know, they started in 2010 and tried to coin the changes. We see a decrease over the coming years in hepatitis C, an increase in fatty liver disease, an increase in liver cancer, stable situation HBV and rare liver diseases and alcohol liver disease. This may be different in different parts of the world. Nevertheless, the recent therapeutic advances in viral hepatitis have reshaped the liver disease landscape, impacting on the types of patients encountered in liver practice. And we all agree that early identification of patients at risk of liver disease is important to ensure patients that they receive appropriate management. When we look at strategies which are required to optimize every part of the cascade of care and achieve cure for all patients, and this is independent of the etiology of liver disease, we have to acknowledge that there are barriers at every steps of cure in the cascade. We have lack of awareness of liver disease. We have lack of screening programs. There is a lack of referral to specialists. There is a fear for treatment costs. And we still have to improve on treatment efficacy, in particular outside the hepatitis C field. However, there are solutions. We have to improve education, awareness for liver disease. We have to increase the linkage of screening programs to diagnosis and care. And today we heard, as an example in hepatitis C from Michael Fried, how successful the primary care physician champions program, the telemedicine programs are already in the United States to link to care. Then certainly there need to be optimized cost negotiations between payers and providers. We need to have better training of doctors and also the trained doctors need to be able to rely on effective clinical infrastructures. And then certainly we need to have clinical research, and at the moment we are living in the area of drug development, of NASH, and you heard about this today. We heard in several talks today about the WHO goal for treatment and for elimination. In particular, this was also outlined by Stefan Solzheimer and by Massimo Colombo, that we have made significant progress in prevention. 90% of infants have HPV birth dose vaccination. I think this is a major success. 100% of blood donations are screened in many countries, but not all countries of the world. And 90% have access to safe injection in many countries, not all countries of the world. And the target for elimination in B and C is testing people. 90% should be aware of the infection, and 80% should be treated. This is the goal of WHO for elimination of viral hepatitis. However, the patient that presents to the general physician, general practice, it's usually that the patient presents with an abnormal ALT level. The first prerequisite is that the primary care physician needs to test for ALT. Usually it's mildly elevated, however the cause of liver disease is unclear. Based on this information, what are the challenges in terms of diagnosis and monitoring? What we have to acknowledge as challenges when dealing with abnormal liver blood tests is that 20% of all liver blood tests are measured abnormal. Less than 10% of patients with a diagnosis of abnormal liver tests are aware of an existing liver disease. And 50% of those with end-stage liver disease have not noted previously abnormal liver function tests. There are various causes of liver disease. We heard excellent talks on all these different, on NAFLD, on alcohol, hepatitis B, C, drug-induced liver disease, and in the last session on hemochromatosis and Wilson disease. However, the practice needs to change so that significant liver disease is detected earlier and not missed. And therefore, the question is, which type of pathology comes to mind when a patient presents with abnormal ALT? This is a rather weird question to you because you are specialists. The majority of you are hepatologists and gastroenterologists. But what do you think that a primary care physician primarily thinks of? Hemochromatosis, hepatitis B, hepatitis C, alcohol-related, drug-induced, NAFLD. Do you have a possibility to vote with your iPhones? If you don't have an iPhone at hand, I'm sure Gilead will provide you with one. In the last version. Yeah, so I think this is no surprise. Nobody thinks of hemochromatosis. This is interesting. Okay, thank you very much. Now, I think we switch gears a little bit. We have 3 cases that we would like to discuss with you. The one is on hepatitis C. Then we have a discussion on hepatitis B, and finally on NASH. And I would like to discuss with you the treatment that is available today and how we can achieve the goals of treatment of elimination by medical therapy. This is a cartoon that is shown on many meetings. This is a projection who of the countries will be able to reach the WHO elimination goals. Here you see the green ones. We heard from Dr. Fried, Iceland, only 1,000 patients with hepatitis C. This may be the first country where there will be an elimination. We have seen significant progress in Egypt. We heard about this. Germany changed in recent years from green to yellow. And we have some countries where Dr. Zoitzam mentioned he thinks that only a vaccine will be able really to lead to elimination of hepatitis C. We have to discuss what are the barriers to curing all patients and reaching elimination goals. How can we address these issues? And this is how we started. The patient coming to a general practitioner, mildly elevated ALT. It's not clear what is the reason for that. Now we have a patient, female, 36 years old, professional lifestyle, no current health issues, recently moved in the area, visiting the GP, introduced herself. He does a liver function test eliminated, and he's wisely enough to test for hepatitis C. And we've seen data that only a proportion of GPs is testing for hepatitis B or hepatitis C. Antibody positive, RNA positive. So in the management, the traditional approach is, if the hepatitis C is diagnosed, to transfer him to a specialist. However, then there becomes the assessment of genotype, the assessment of liver fibrosis. And there are other considerations. In many areas of the world, the hepatitis C population is growing. I think the average age of an hepatitis C patient in Japan is above 60, and this is in some areas of our world as well. Then the question is there a cirrhosis or not? Because this used to have a major impact on the treatment regimen. And then older patients have comorbidities. They have hypertension, they have diabetes, or the particular risk groups, they have potential drug-drug interactions like HIV co-infection or the transplant population. And we have a treatment monitoring, and finally we have to prove cure, and then in particular the cirrhotic patients, they have to be followed up. Dr. Zeutzer made the case that we may not have the resources to follow all the patients, but I think every cirrhotic patient needs to be followed. However, when we would think of shifting treatment to the primary care physicians, treatment should be more simplified. And the question is whether we can reduce on the workup of the patient before starting treatment. One of the problems is that in the different cascade of management, we first have to diagnose the patient. When we do an antibody test, we need to do an RNA test. Then once the infection is established, we need to link patient to care, and then we certainly, after cure, have to follow up the patient. Everywhere we lose the patients. This is something we have to work on, which is very important to improve in the future. When we discuss the pre-treatment assessment, we still do genotyping. The question is whether we have pan-genotypic regimen available. The question is, how do we test for fibrosis, for staging of liver disease? And we already saw in recent years a major shift from liver biopsy to non-invasive technology for assessing liver fibrosis. And then we have to discuss how important are comorbidities and medications in the management of the patient. We would like to see the treatment as simple as possible in order to reach out therapies to primary care physicians. One advantage is pan-genotypic therapy, which should be available for all eligible patients to treatment. And then the management of patients should be easy for the prescriber, but also for the patient with minimal dosing restrictions. And there should be an easy step to eliminate hepatitis C, from testing to treating, cure, and follow-up of the patient. We have seen in recent years the development of all these regimens. We have seen a lot of talks today on all of the regimen. I would like to concentrate on the pan-genotypic interferon-free regimen. There are 3 available. Mainly this triple regimen is for rescuing patients that failed DIA therapies, and then we have the fostrovalpadosvir and the GP regimen as pan-genotypic regimen available in many parts of the world. So the problem is that we have these the good thing is that we have these therapies available. Sofvel, 12 weeks of treatment, shorter duration of treatment for the GP regimen. However, for special patient populations also increase, in particular depending on cirrhosis and treatment experience. The Sofvel is also approved for the decompensated liver disease, so it's not so important to diagnose whether the patient has cirrhosis or not. And in various studies, F3, F4 and are taken together in the trials, It's very important to diagnose decompensated liver disease because here limited availability of regimen. When we look at the data, you see all these pangenotypic regimen have excellent results. This is for GP, and there's always been the criticism that these regimen prove to be highly efficacious in the prospective trials. But I think what we learned in hepatitis C, also thanks to very large registries, there are large registry in France, the Target or the German hepatitis C registry, and the real world experience has proven to be as effective as the phase 3 trials. And I think this has been a surprise. This is the Sofwell for the 12-week regimen, high number of cirrhotic patients in these trials, and you see overall the genotype, excellent results irrespective of genotype, cirrhosis statement, and the history of treatment. And also real-world data also have as good results as in the clinical trials, independent of cirrhosis or previous treatment. However, we have special patient populations and an increasing age, in particular in the Western world, of the hepatitis C patients. This is from a Spanish study, retrospective multi-center observation study in Spain, evaluating comorbidity and DDIs among patients. And you see the patients have up to 30% as a concomitant disease, arterial hypertension with the treatments. And you see here is the data that show that there is comorbidity and the potential recognition of DDI interactions. This has to be distinguished whether we are dealing with a general population where statins are an issue, whether these are females with the use of contraceptives, or the PVID population, or the transplant patients, or the HIV co-infected patients. These different populations here are usually taken care of by specialist physicians. When we come back to our patients, this patient was treated with Sofwell for 12 weeks, SVR was achieved, and then continued to have surveillance for HCC because of cirrhosis. You see the reduced platelets. In the future, with a pangenotypic regimen and reaching out the therapies to GPs, certainly the pretreatment assessment will be reduced. We will not be necessary to check for genotypes. We may not be necessary to check for cirrhosis, but looking for whether the patient is decompensated. And I think that there should be an easy approach that from test to treatment, we should not lose patients, but also we should not lose patients in the follow-up after cure of treatment. The Australian experience with hepatitis C has been very successful. Australia has been very successful identifying the source of new infections in their prisons and treating patients successfully in the prisons. And they also have experienced and provided data that from 2016 on, what non-specialists could prescribe DAA therapies in Australia, which significantly improved the access to care, and in particular general practitioners increased the rate of therapy. So hopefully in the future, within the HCV patient cascade, we can do differently in order not to lose patients and to increase the access to treatment in order to achieve the WHO criteria. On the way to HCV elimination, we have to think globally but act locally. Education is very important for the patient and the physician, certainly collaborations with primary care physicians. We have heard a talk on the special patient populations. Dr. Boulier has discussed the few patients that do not respond, so we need still collaboration with specialist center, and we need to have employed all the different stakeholders. We have a special area where still we need improvement. These are decompensated cirrhotic. The transplant populations very soon will be free of hepatitis C, as will be the hemophiliac patients. HIV, HCV co-infected will not be a special population anymore. And we know that the PVIDs and prisoners here is where the new infections occur, and therefore the treat as prevention strategy is in particular relevant for this population. So these are the challenges we have, but this is hepatitis C. And we will now hear and listen whether hepatitis B is picking up and may be as successful and simple as hepatitis C. C is simple, B may be more complicated. Thank you very much.
Thank you, Michael, for showing us that simplicity is important, that we have the tools, excellent treatment, and we should screen more patients and link to care. So now we move for Hep B, and Hep B is a major topic. We have many colleagues in the attendees with countries from high endemicity. I see colleagues from Africa, from Asia, from all over the world. And I think it's very important to learn how to manage the patients. And we have Georges Papatheodorus who will explain us. So we know that for Hep B, there has been a fantastic drug development. And now we have treatments which are safe, well tolerated, and with high efficacy. And we say that if a patient is well managed, he has a normal life expectancy and a normal life if he has need treatment. So let's look to the patient case. So this is a lady, 46 years old, and she recently moved and she visited the GP who make transaminases, and we have increased transaminases. She smokes 10 cigarettes per day, and she received the blood transfusions in the 30s, and then she has been tested for Hep B. You can see also that she has comorbidities, obesity, diabetes type 2, and hypertension. So she may have also a metabolic syndrome associated with Hep B. You see further investigations. So the DNA was 45,000 international unit. ALT was increased. Genotype D, infection. And FibroScan, fibrosis evaluation, 12 kilopascal. So maybe advanced fibrosis, F3, Hep B, naive, never treated, no Delta co-infection, no HIV or Hep C co-infection. So we will look with just how we monitor, how we follow these patients. So a question, how would you manage and monitor these patients? Repeat the test after 6 months, monitor the patient for hepatocellular carcinoma, carry out a biopsy, treat the patients, answers 1, 2, and 4, and do all of the above. Please vote. So it's interesting because if you look for number 4, treat the patients. Number 5 is also answer 4, you treat the patients. So I think that the majority among the attendees will treat these patients because of the bridging fibrosis, the advanced disease, the comorbidity, the Hep B, but we can also discuss this later. Finally, carry out a biopsy, 1%. So it will be also interesting to see because liver biopsy has been reduced with non-invasive evaluation. And monitor the patient for hepatocellular carcinoma. Very few people, I think it's a debate because some people will say, if you have advanced fibrosis plus comorbidity, should we maintain surveillance? I think that many guidelines are in favor for surveillance. So if we go back to revisiting natural history, you see there has been new guidelines for Hep B who have been revisited. And in the guidelines, there has been new definitions. It's very similar, but immune tolerant is now infection. So the idea is to separate Hep B infection when there is no liver lesions from hepatitis when you have liver lesions. And so immune tolerant is now chronic infection and also inactive carriers. And when you have lesions, so it's still E-positive chronic Hep B and E-negative chronic Hep B. So this patient has chronic hepatitis B. And now it's my pleasure to ask Georges Papatheodorou to come and to explain us. He was part of the guideline, the expert, and he has a very big experience with patients, how he managed the patient. Georges.
So, good afternoon. It's really a pleasure for me to participate in this symposium. And we continue from where Tariq left us. We keep in mind the phases of chronic infection. We also remember that we treat patients with active chronic hepatitis B, as we cannot eradicate the virus of hepatitis B. And let's see how all these translate into our clinical practice and which actually are the treatment indications. So you know that treatment indications typically include HPV DNA, ALT, and severity of liver histological lesions. And according to the European guidelines, we have for both the antigen positive and the antigen negative chronic hepatitis B patients, HPV DNA above 2,000, plus elevated ALT, plus at least moderate liver histological lesions, either necroinflammation or fibrosis. But if you think deeper in clinical practice, what we try to do when we think of treatment indications is, can we identify patients who do not need interventional liver biopsy? And yes, we can. Sorry, but it doesn't respond to the mouse. Anyway, okay, so you see that cirrhosis, it's easy. We don't need to think of it. So if we diagnose not only decompensated, but even compensated cirrhosis, either by elastography or by ultrasonography or by doing an endoscopy and finding liver esophageal varices, then we don't need to think of ALT levels. We treat the patient with any detectable HPV DNA. We also treat, regardless of liver histological lesions, patients with obviously active chronic hepatitis B, as was our case today. So our patient had ALT above twice the upper limit of normal, plus HPV DNA above 20,000. So we treat these patients not because we don't need a liver biopsy, but because we know that if we perform a liver biopsy, we are going to find at least moderate, usually more than moderate liver histological lesions. And we also treat patients who have e-antigen positive chronic infection and who are older than 30 years of age, because we know that there is higher probability of these patients to have severe histological lesions, even if they have normal ALT. The age cutoff was 40 in other guidelines, and still maybe 40, but in Europe we don't have so many these type of patients, so we decided that we should remain on the safe side and treat earlier than later. And we also think of the family history of the patient. If we have a patient who has a family history of hepatocellular carcinoma or cirrhosis, or a patient with advanced extrahepatic manifestation, we treat the patients even if the typical guidelines and treatment indications are not fulfilled. So which type of agents we might use? Theoretically, we could use pegylated interferon, but I'm sure you agree with me that this is the least preferred option by both the patients, but also by the physicians. So we usually don't use pegylated interferon, particularly for such patients who have relatively advanced liver disease. And in any case, the majority of our chronic hepatitis B patients are treated with an oral agent, 1 pill per day, either by tenofovir disoproxil fumarate or tenofovir alafenamide or entecavir. And are there patient characteristics that favor the selection of one of the agents? Okay. Yes, there are, and these are related to the preference of TAF or entecavir instead of TDF in patients who are already with some problems or at a risk for developing renal or bone problems. And according to the European guidelines, at least, these patients include those who are older than 60 years of age, those who have bone disease defined as chronic steroid use or other medication, who worsen bone mineral density, those with a history of fragility fracture, osteoporosis, and for renal problems, eGFR below 60, low phosphate, albuminuria, and hemodialysis. Okay, so we move 2 slides. Anyway, the previous slide, okay, thank you very much. We know that our chronic hepatitis B population is changing. Our patients are becoming older, and this reasonably results in increasing proportion of comorbidities. These are data from the United States, but we also have data from other countries, and I'm sure that similar data can be produced in any countries for chronic hepatitis B patients. What we see in this slide is that patients were divided into 3 periods, 5-year periods: 2000, 2005, 2005, 2010, 2010, 2011, 2015, and then we see that the proportion of patients with osteoporosis has tripled from the first to the third period, almost similar increase to the proportion of patients with osteopenia, 5 times increase in the proportion of patients with chronic kidney disease, and similar increase in the proportion of patients with type 2 diabetes, and of course at risk for renal and bone problems. So when we start treatment with an oral agent, the first main endpoint we try to achieve is HBV DNA detectability. And you all agree that we have now many long-term data, better design for the tenofovir trials, TDF trials, not so optimal design with Entecavir trials, but the data have been confirmed in real-world evidence, and we know that the vast majority of our patients, 95% or more, will achieve and maintain undetectable HBV DNA if they receive the drug. And we don't have resistant issues in nucleotide naive patients, but we don't achieve HBs antigen loss. In the majority of our patients, we can achieve it in up to 10%, at least with TDF, in E antigen positive patients initially, and very, very few actually E antigen negative cases. The next issue we should consider when we start treatment with a long-term monotherapy is safety. So here you see the safety data for Entecavir. I'm sure you agree with me, this is a safe drug, and you see very low rates of drug discontinuation in the studies, 1.2%, very few deaths from any cause, not from liver disease, very few serious drug-related adverse events, and very few renal events. One concern that has been shown from long-term studies is how this agent is effective in a specific settings. The patients with lamivudine resistance, we know now that more than 50% of patients will develop Entecavir resistance after 5 years if they are treated with this drug. We are not going to read all this text which comes from the drug SPC, and because you agree that this is an agent that should not be used in lamivudine-resistant patients, this is in any guideline today. Moving to the safety of TDF, these are safety data from 8-year studies, and we see that the drug discontinuation rate is low, around 2%, low death rate, low serious adverse events related to the drug. But when we move to the renal problems, we see somewhat higher rates compared to Entecavir, not high, but relatively higher. And if we focus in the last, before the last row, we see that 3.4% of the patients at the end had to reduce the drug dose or discontinue either temporarily or permanently tenofovir, TDF. And in the different studies, 2 to 8% of the patients who are treated with tenofovir have been shown to develop renal problems. And because there is no predictor of who are the patients who are going to develop renal problems in the TDF SPC, it is written that this agent should not be used in patients with renal impairment if the benefits exceed risks. There is a problem with, okay. And we now have, of course, data with TAF. TAF is tenofovir with a different pharmacokinetic profile compared to TDF. The registration phase 3 trial was comparative trial between TAF and TDF, and here you see the latest 3-year data. On the left, the HPV DNA detectability rates are identical, I would say, in both e-antigen positive and e-antigen negative patients treated either with TAF or TDF. Of course, here we see relatively low numbers compared to the TDF and Decavir slide I showed you before, but these are intention to treat analysis data. Any patient who just missed the visit or discontinued the drug early counts as a failure. And an interesting observation in the TAF trial was that TAF compared to TDF achieved higher rates of ALT normalization. Moving to the safety and looking at laboratory parameters, first of renal function, it was clear that the safety profile of TAF was better compared to TDF. So you see that the estimated GFR change is practically nothing, no change in the patients treated with TAF, although there is a decline, particularly in the first year, the gray line in the TDF-treated patients, and this difference remained throughout 3 years of treatment. And if we look on the right side of the slide, in the tubular, proximal tubular markers, retinol binding protein to creatinine ratio of beta-2 microglobulin to creatinine ratio, we see that we have worse changes in the TDF-treated patients compared to TAF-treated patients. And similar data we see with bone mineral density. So again, no change over the 3 years of TAF therapy and worsening of bone mineral density, not only during the first, but also during the second and even during the 3rd year of TDF. And on the right side of the slide, we see that the proportion of patients, if we focus on the red part of the histogram, the proportion of patients who had at least 3% decline in bone mineral density was below 20%, around 18% in the TAF-treated patients, and more than 40% in the TDF-treated patients after 3 years of therapy. And not only the registration trials have shown favorable safety profile of TAF compared to TDF, but this is now confirmed in clinical practice. This is an interesting study from Japan showing data that do not come from the phase 3 trial, because in that study, the Japanese colleagues included patients with renal impairment. So in the study, all patients had GFR above 50. So in this slide, what we see is that patients were switched to TAF from adefovir or TDF. Then even patients with, I would say, moderate to severe renal impairment, grade 3, the red line, not only they didn't worsen further, but they had some improvement at the end. So this is interesting. So our patients was treated with TAF because the treating physician thought not only of the efficacy, which is similar for TAF, TDF, or Entecavir, but also of the safety profile in a patient who had diabetes and is at risk for renal at least and even bone problems. Of course, this patient needs surveillance. This is a question, who are the patients who need surveillance? That was a patient who, at least according to the page B risk score, which is recommended to be used for Caucasian chronic hepatitis B patients, this was a patient at moderate ACC risk because she was above 40, between 40 and 50, and she had platelets below 200,000 per cubic millimeter. So that puts this patient at the medium ACC risk, and this patient needs surveillance. The next question is whether treatment will reduce the ACC risk in this patient. And this is probably the best Entecavir study in ACC, in chronic hepatitis B patients. This is a study from Japan, probably you know it, and it is not a randomized trial, but it included historical cohorts, but very well matched according to a propensity score. And what we see is that Entecavir, compared to no treatment in the past, resulted in significant reduction of ACC risk in the cirrhotic patients, but the low risk in the non-cirrhotic did not change. We have data with TDF, but this is not a trial or cohort study, but this is the ACC risk in TDF treated patients in the registrational trial, and you see that after the red bullets is the actual ACC cases in the TDF treated patients, and the lines show what was expected according to different ACC risk scores, and we see that after year 3 there's a clear difference, so the ACC is decreasing. And very recently we had a large but provocative, I would say, study, cohort study, large cohorts from South Korea, very well matched on several characteristics, even very well matched according to different ACC scores. And what we see is that there is a difference between the Endecavir and TDF treated patients, and the difference becomes clear after year 2, definitely after year 3. Whether this is confirmed in other studies and will affect our treatment decisions in the future, in agent selection, we're going to see, but this is an interesting observation. So, in summary, whenever we have to treat a chronic hepatitis B patient, we should consider not only the efficacy of the agent, but also the safety of the agent tailored to the patient profile we have in front of us. And compared to TDF, TAF is definitely associated with improvements in renal and bone mineral density markers. And this has been shown not only in the registration trials, but now it is in emerging real-life data. Thank you very much. And I think we stop here with hepatitis B, and I give the podium to Professor Mans to continue with the NASH case.
If you remember, one of the first slides I showed was this editorial by Tom Carlson and Frank Tucker with a huge increase in fatty liver disease. So this is something we are ending up with on a NASH patient case, identification, screening, and diagnosis of patients with NASH. These are the disclosures of both of us. And remember, we started that a patient comes, a patient here recently moved in the area, visits the GP. The GP, at least in Germany, first is allowed to do some laboratory tests and bill for it, and all of a sudden ALT increased, and the cause of liver disease is unknown. The patient was not aware of abnormal liver tests. Again, a lady, but not as in hepatitis C 36. It's now a lady of 55 years, professional lifestyle, and non-smoker, non-drinker. Hard to believe if it's a German patient. But BMI of 33.5, so obesity, diagnosis of type 2 diabetes, managed with metformin and GLP-1 receptor agonist, portal hypertension, not portal hypertension, arterial hypertension, managed with lisinopril, and a normal, almost normal kidney function. So the laboratory tests were anti-HBs positive. So I would also like to know anti-HBC, because this is a generation, 58 years old. There was no universal vaccination at that time when this patient was born. And anti-HCV is negative. Then we have this elevation, slightly higher AST. We have cholesterol, triglycerides, HDL, raised gamma GT, and a moderately decreased platelet level. So which tests would we do next? FIB4, ELF, FibroScan, ultrasound, NAFLD, fibrosis score. So could you please vote now? So this is interesting. FIB4, at least the majority of audience is not from Germany. ELF, 0.9% is surprisingly low. FibroScan in France, surprisingly low. Ultrasound, I'm sure, these are the Germans, I think. This NAFLD fibrosis score, 15.54%, but this is the surprise. 6.4% liver biopsy. And when I started hepatology in 1977, all the congresses of liver disease were dominated by pathologists. Hans Popper, Valère Desmet, Peter Scheuer, and they were giving the big state-of-the-art lectures, and they started all with this blue and red science with HE staining, whether there was necrosis, whether there was fibrosis, and then the philosophy started, whether it's viral hepatitis, autoimmune. Nobody at that time talked about fatty liver disease. Many people talked about alcoholic liver disease. But I think this is very, very interesting. So liver biopsy, I think, in an area that we do trials with placebo arms in NAFLD, where we are asked to convince the patients, if they get placebo, still to tolerate 2 biopsies. I think if we not even do biopsy in the workup, I think this is a change. If I would have asked you 10 years ago, I presume this would have been double. So this is my reading of this. But now Dr. Sanyal, the world specialist on NAFLD, is now solving all the problems and telling us how we treat in the future.
Dubious distinction. Now, I tell you, the patient came in with nausea and vomit and abdominal pain, so let's not forget the patient still has nausea and abdominal pain. We love our liver enzymes, but I'm just saying, my disclaimer is that we're hepatologists, so we're going to focus for purposes of this discussion. But if it was a real life case, you may want to also think about what's actually why the patient came to you. So I think, but it makes a very important point that patients will frequently come for an unrelated reason, and you will discover that they indeed have something going on with their liver. Because the liver is a very forgiving organ. I mean, you guys are all hepatologists, so I think I'm preaching to the choir here. But the reality is, it's worth repeating, that the liver is a very forgiving organ and will not tell you something is wrong unless it is really, really wrong. And so you have to look for liver disease. And so we see over here that this patient, the FIB4 was greater than 3.25. The FibroScan was 17 kilopascals, and the cap is 300. So what does this tell us? Well, the cap tells us that the patient has fat in the liver. The FibroScan and the FIB4 both tell us that the patient has advanced fibrosis. So these are clearly past the threshold that we would think about advanced fibrosis, cirrhosis. And if you had not looked past these initial symptoms that the patient had and looked at the patient's overall profile, you would never have made this diagnosis. So it's really important that we continue to pay attention to that. My slides are stuck. Can I get the slides to move? Oh, thank you. Historically, this field is all anchored in histology. And so the people who started the field, and even the original description of non-alcoholic steatohepatitis as a distinct entity came from his pathology. But pathology has so many limitations. So all of you realize this, so I'm not going to repeat those, but non-invasive tests are where the action is. Because you need to be able to make the diagnosis in your office very simply with a minimum amount of invasiveness. And basically, they fall into 2 buckets. You have a bucket where you do a blood test, and the blood test comes back and gives you a score, or you do some sort of a procedural test to evaluate the physical properties of the liver, and ultrasound and elastography are the most simple ways of doing that. Now, there are a lot of blood tests on this slide, so how do you really do this? So I think we heard from the hepatitis C paradigm. Can we move to the next slide? Oh, this one, not on the laptop, sorry. Okay. I got it. Okay, so of the blood tests, let's make this really simple. The FIB4 test, which we've seen multiple times today, age, AST, ALT, platelets. This was developed actually by one of my fellows when he was still in training, Richard Sterling. But it has really stood the test of time and has been validated across multiple groups two numbers, less than 1.3, very high negative predictive value. The likelihood of having significant fibrosis is very, very low. On the other hand, if it is more than 2.6, think about more advanced fibrosis. There are similar thresholds for the NAFLD fibrosis score, but in the middle, there is sort of an indeterminate range. And that indeterminate range, we recently looked at a semaglutide trial that is ongoing at the baseline data, appears to be much larger for the NAFLD fibrosis score. So what do you do with that indeterminate score? These are data shown at the ASLD recently, where you take that and you can use a more confirmatory test. This could be either transient elastography, and if you have available ELF test, you could use something like that. Now, you can argue about whether these are the best tests. I think this may still evolve, but the principle is, for that indeterminate zone, move from your blood test to an elastography-based test or some other better, more sense-specific test, so you can nail down whether the person indeed has significant fibrosis or not. Why is this important? Because fibrosis matters. Fibrosis determines proximity to cirrhosis, and there is collinearity between the scarring inflammatory disease in the liver, heart, kidneys, arteries, and so it correlates both with all-cause mortality as well as liver-related mortality. And typically for liver-related mortality, stage 2 and upwards is what we call clinically significant fibrosis. So that's when you have particularly increased mortality risk. But we also know that in a primary care setting, especially our colleagues are underdiagnosing this, even though they're getting lots and lots of liver enzymes, and as it was shown earlier, most of those are being ignored. And this is data from the US, from the Veterans Hospital System. And you can see even when the patient, it showed up with the abnormal liver enzyme and they were given a reminder on the electronic medical record system, large number of patients were actually ignored. And so, this is a real problem because 3% of these people actually had very high fibrosis risk. So the magnitude of ALT elevation looks like is the only thing. If it's 500 or 600, it triggers a referral. But if it's slightly elevated, most primary care physicians ignore it. And that's a problem. And that's what we have to change, that way of thinking. We know patients with diabetes are particularly at risk of having advanced fibrosis. Here are data showing NAFLD using different diagnostic tools and overall prevalence of advanced fibrosis. So we know somewhere between 60 and 75% of diabetic patients will have excess fat, and up to 20 to 30% of these patients across different studies will actually have significant fibrosis. Type 2 diabetes also increases the risk of hepatocellular carcinoma. In multiple studies, this has now been shown. This is very well established. And that's the basis why the practice guidelines from Europe actually say you should be screening type 2 diabetes patients for fatty liver disease. Now, in the US, we don't do that because for us, the screening guidelines require not only that the disease has to be there a lot, but you have to have an effective proven therapy that is approved, which we don't yet have. So I think once that happens, the two guidelines will look similar. So what do you do now? Guidelines recommend surveillance. If you have someone with a high stiffness, with a high probability like 17 kilopascals, screen for hepatocellular carcinoma like you would with any other cirrhotic patient. Patients with hypertension should be monitored. No, this is a no-brainer. And then patients with NASH cirrhosis should also be evaluated for varices, and there are now Baveno guidelines based on elastography and platelet counts to determine when you do this. The treatment of NASH is part of a multi-system disease, so the optimal management requires integration of a variety of things, from making the diagnosis, managing lifestyle, therapeutic approaches, fibrosis staging, and follow-up, and requires a diabetologist, cardiologist, lipidologist, nutritionist, hepatologists all to work in concert. So we'll finish over here with this proposed risk stratification, where when we suspect patients with fatty liver disease, essentially ask about alcohol consumption, so you can put that aside, evaluate for Hep C, Hep B if in the appropriate circumstances, and then if your pretest likelihood of having fatty liver disease really goes up when you've excluded those two other things. The next thing you want to know is how much scar tissue is there, because the question you want to ask is this person going to die of their liver disease? And that's dependent on amount of scarring. And so the FIB4 provides you a very easy way of doing it. If it is less than 1.3, they are in a low-risk bucket. If they are intermediate, it's between 1.3 and 2.6. And then there's a high-risk profile. I want to also add in the high-risk profile, if the AST is higher than the ALT, if the platelet counts are below 150,000, you should seriously consider that this patient already has cirrhosis and manage them as though they have cirrhosis. And then, of course, liver biopsy, whereas it used to be for everybody to make the diagnosis of NASH 10 years ago, now it is a much more restricted population on a case-by-case basis. So this is sort of where we have landed in the last 10 years in terms of diagnostic evaluation. So I'll summarize by telling you that type 2 diabetes is an important predictor of advanced fibrosis. That's an important take-home message. Although liver biopsy is the reference standard, it is an imperfect reference standard, and non-invasive tests have very good value. And the evaluation of routinely available non-invasive tests demonstrate acceptable diagnostic performance, and a multidisciplinary approach is required for the management of advanced fibrosis due to NASH. So I'll stop there.
Thank you, Arun, for this excellent lecture. We understand why you are a top leader in NASH. So we will start the discussion. Feel free to use the microphone if you want, if we can have some light. So we have one question for each of you. I will start with George. Many people said, okay, we understand, we start therapy, but what would be the minimal monitoring for a patient under NUCs who is treated?
Yeah.
Could you explain for people? They like to go out with a prescription, with some take-home message.
Sure. This depends probably on the country and the system, but the minimum follow-up should be ALT every 3 months, HBV DNA during the first year, HBV DNA every 6 months during the first year. And after the first year, what we do now in most of the countries, we're talking only for patients who are treated with a high genetic barrier agent, so Decavir, TDF or TAF. So after the first year, we follow the patients every 6 months with ALT and HBV DNA every year. We also need to follow the patients for safety markers, depending on the agent, but also on the risk for problems. So if we have a patient who is at risk from his own comorbidities or from his age or whatever for renal disease, whatever the agent, we follow the patient. Or if the patient is using TDF, we follow the patient regardless of the risk. So this follow-up includes creatinine and estimation of creatinine clearance, and for TDF also phosphate levels for tubulopathy. And the frequency of safety follow-up is similar to the ALT follow-up. So every 3 months during the first year, every 6 months after the first year.
Thank you, very clear.
We should also not forget those patients who need surveillance for ACC. We mentioned that in the presentation, so this is very important because this is the main risk of our chronic hepatitis B patient. ACC still develops even after several years of effective therapy. We need to diagnose it early.
Thank you, very clear. Aaron, one question for doctors is that could you identify among the NAFLD, NASH population, the patients who will die from liver? Because if they will die from cardiometabolic, for diabetes, finally, we don't care to manage the liver. So what is your advice when you see a patient with NASH?
Right.
How to identify?
So I think the first thing, we do care. I won't say we don't care completely because you can't guarantee that somebody's going to die from cardiometabolic disease unless they're almost dead. I think the most important message is that the amount of fibrosis. There are, as I was talking earlier in the earlier session, there are two concepts of disease activity and disease stage. Disease stage refers to how far the disease has progressed to cirrhosis. And since the majority of liver-related mortality is linked to cirrhosis, the proximity to cirrhosis is a marker of your proximity to death. And so there is no surprise that fibrosis stage, correlates very tightly. So it is a really important part of our diagnostic evaluation is to understand how scarred up the liver actually is.
And Michael, one question. when you treat many patients, you have treated many patients with Hep C. What do you do for patients with F3 bridging fibrosis, cirrhosis, who have been cured from Hep C? How do you manage in your clinical practice these patients?
First of all, I think the distinction between F3, F4 is rather arbitrary. We know that the risk of cancer development is continuously increasing with the stage of fibrosis. And we should not forget that the liver biopsy is, I think, 1/10,000 of the whole liver. And fibro scan is a little bit more, but also not covering the whole liver. And we should not forget that this F1, F2, F3, F4 was created by French colleagues under the leadership of the pathologist Bedossa, and based purely on hepatitis C patients. So now we use this for all kinds of liver diseases, and you see that 6.4% would do a liver biopsy in this lady with NAFLD. So I think we cannot just extrapolate the data. Although the FibroScan has a good distinction between cirrhotic and non-cirrhotic, I still think that F3, F4 should be regarded as a common risk group. And several of the studies in NASH and in hepatitis C already pooled together F3, F4. I think in the treatment management of hepatitis C, it's rather important whether the patient had a past decompensation or not, or whether he has decompensated liver disease. And we see that in treatment outcome, compensated cirrhosis has the same result as F3. So it's rather the question whether the patient had decompensated liver disease. There's also one other aspect. In the old days, when we did not achieve 100% plus cure rate, we knew that the response to treatment was related to the degree of fibrosis. And again, here in particular, portal hypertension and thrombocytes were regarded as a surrogate marker. And cirrhotic patients with portal hypertension in particular had a decrease in response rate to antiviral therapies. So I think F3, F4 doesn't matter that much. But this leads me to a question to Dr. Arun Sanyal. And this is, we learned in the past that in hepatitis C you only get cancer when you have cirrhosis. In hepatitis B you may have cancer without cirrhosis. And then we learn in NASH 25% have cancer without cirrhosis. So what do we do with follow-up? We say we should only follow the cirrhotic hepatitis C patients after cure. How should we follow the NASH patients?
I think the NASH, well, first of all, we haven't cured, we're nowhere close to curing NASH in the cirrhotic population. So I think if you have somebody with cirrhosis and NASH, or NASH with cirrhosis, you have to do the HCC screening as long as the patient is alive, based on today's knowledge. The bigger challenge, which is very difficult, is what to do with the person who has fatty liver, no fibrosis, because we know if you look at cohorts of people with cancer that is associated with non-alcoholic fatty liver disease, about, depending on the cohort, 25-33% of them are not in cirrhotic patients. If you flip that, if you take cohorts of fatty liver disease patients and look at how many had cancer, that's like 0.1%. So the issue is one of the denominator, which is extremely high. So there's a big unmet need currently to develop an enrichment strategy within that population that will allow us to implement more effective screening tools. So that's an area of really ongoing work, but it's sort of, we don't have a good answer at this time. So everybody's left to do what they feel best.
Thank you very much. I think we are running late. We wanted to close at 8, so we have 2 minutes left, one for me and one for Tariq. I summarized the whole meeting, the whole day in 1 minute now. I think liver disease has been underestimated. And I may mention that the EASL has, together with the Lancet, launched a EASL-Lancet Commission on Liver Disease, where we want to really highlight that what we heard today already, that liver disease is a major disease threat for global populations, in particular also for Europe. We have achieved treatment. I think hepatitis C is one of the big success stories in medicine. We all agree on that. And the simpler the therapy is, the better we reach our goal of the WHO goal to eliminate viral, at least in the important population, and this is the PVIDs and the prisoners where the new infections occur. I think we have pan-genotypic regimen and we can treat decompensated disease, and the therapy will reach out to practitioners. Hepatitis B, I think we know from the liver congresses that the rooms with hepatitis C get emptier and emptier, and the room with hepatitis B are filling up. We heard a talk today with a slide with as many more companies that ever have been involved in hepatitis C therapies are now in the therapy of hepatitis B. But I think with entecavir and tenofovir and TAF, we really have a regimen available that we can prevent progression, prevent cancer development. And so I think, which I also want to remind, is in 1990, the late Sheila Sherlock wrote an editorial in the British Medical Journal stating that hepatitis B is a contraindication for liver transplantation because everybody got reinfection and 50% died after 3 years. But now hepatitis B is among the best indications for liver transplantation, and this is due to these antiviral drugs which can prevent reinfection. So, and then the new disease, I mean, everybody who thinks that the liver is disappearing from the agenda, no, thanks to fatty liver disease. But what Arun Sanyal mentioned, it's part of the metabolic syndrome. They are comorbid patients, there's obesity, there's diabetes, there's co-medication. And I think this is a very, very big challenge. And I think we as hepatologists, we not only have to teach the other disciplines about liver disease, we also have to learn much about diabetes, nutrition, and maybe also to how to exercise first ourselves and then our patients. So I think I would like now to hand over for the 1 minute for Tariq Asala to close up.
So I agree with Michael. I think we have to maintain high level of education to improve screening for all liver disease and linkage to care. And I wish you, all of you, a nice day in Paris, a nice day for the next day for the meeting. Thanks for being so late there, and I would like to thank all the Gilead for their commitment in liver disease and organizing this symposium, and all the speakers were excellent as usual. Thank you, all of you.